Muted?
I believe I am. Can you hear
Yes,
me,
you
ma'am?
are. Uh-huh.
Thank you, Madam Chairman. I appreciate that. Uh, Dr. Brooks, you brought up in your testimony and some of your comments that hypertension and diabetes are a concern. I thought that was interesting because I was reading an article over the weekend that talked about how food deserts, particularly in poor communities, in African American communities, et cetera, lead the folks in those communities to be overweight, thus more hypertension and diabetes. Do you think that that's something we should look at as a part of all of this that we're looking at?
Absolutely. That's one of the primary social determinants of health that is leading to adverse outcomes. African Americans are more likely to be food insecure, 22% versus 12%. And you all know that it's hard to get to the market. We're doing this now. So even under COVID, if you don't have that access, it's going to even be worse. So actions that reduce food insecurity will directly lead to better health outcomes.
Well, and correct me if I'm wrong on this. Part of what I interpreted from that article was that there may be some like a corner store or something, but they're carrying potato chips, frozen pizzas, Vienna sausages, et cetera, all things that are high in sodium and which are not particularly healthy. And because there's not a full service grocery store, even though they might be able to get some food, they're not getting the healthy foods that would help them with their weight issues, hypertension, or diabetes. Is that also fair?
That is true, and that is part of what directly informs the statistics of food insecurity. So access to healthy foods and the ability to purchase it are what define food insecurity.
Appreciate that. I also appreciate you bringing up telehealth. I represent a very rural community where telehealth is also important. It's one of those things I'm now curious if there would be a study because the most rural parts of my district also have higher levels of hypertension and diabetes as well, even though it's not a minority population. It is a poor population that is separated from easy access to full service grocery stores. So that's an interesting point. And telehealth is going to be huge. We've got to get the broadband out there, whether it be through white spaces, whether it be through low orbit satellite, or whether it be through laying of fiber. But I appreciate that. Dr. Roy, I'm going to switch gears completely and go with you about something that you were talking about nursing homes. And we know that the older populations and the nursing homes have been particularly, because of the congregate care, subject to both getting the disease and then obviously because of the comorbidities, there's more fatalities. I had a concept that was brought to me a number of years ago when I was in the state legislature. We actually got a law passed in Virginia to allow a zoning variance for this, and then North Carolina followed suit. And you would basically create a medical cottage, which then could be placed into somebody's backyard so that if I wanted to put my mother-in-law out there in the backyard because she had some issues and there were requirements that you have two needs for daily medical help. But that if I want to do that, I could then have her in the backyard instead of putting her in a nursing home. The concept has never taken off because Medicare and Medicaid don't reimburse that at all. And obviously, unless you're extremely wealthy, you can't afford to rent a medical cottage and stick it in the back yard. But the data that we looked at when we were developing this, the data indicated it would actually be cheaper than nursing homes and you would still be closer to family. Do you think that's something that this might be the time might have come for us to push Medicaid and Medicare to reimburse something like this so that not only would people be closer to their family, but they also wouldn't be in congregate care settings where they're more susceptible to getting a virus like this?
Well, Mr. Griffith, what I'd say is that in the non-public programs, among people who can afford to do it, home-based care is exploding. So overall, it's a trend that we're seeing. It's just that Medicare and Medicaid were designed at a time when none of these things were part of the thought process or equation. So absolutely, we need to update and upgrade Medicaid and give states the flexibility to do more, to pay for care in a home-based setting. Right now, Medicaid, basically, as you said, because of the way it reimburses Medicare to also, but it's particularly a Medicaid problem. It really steers people to these congregated facilities. So that's very, very important. More people should be taken care of at home. It's less expensive and it's also safer. And then we're going to have to really do a much better job of overseeing the way, oversight of nursing homes. There's in theory all sorts of oversight in place, and for whatever reason, it just doesn't seem to ever work. And so nursing homes don't have the ability to do adequate infection control. There are lots of GAO reports and others about this problem.
Well, I appreciate that, and we'll be looking into that more and may contact you. And I don't know how much time I have, if any, but I'm happy to hear from either of the other witnesses on that concept of
I
having
think
that
your time has
medical
expired, Mr. Griffith.
Then I yield back. Thank you, Madam Chair.
Okay, thank you. The gentleman yields back.